Hello, and welcome to this talk on neuro and head-neck on-call cases. The aim is a whistle-stop tour of the conditions that can turn up when you're on call. For each one, we'll talk about the protocol, the main findings, and the complications, the differentials, and a quick reporting template. Hopefully, these will be of use during those super fun night shifts. Let's crack on. So let's start with acute ischemic stroke. Your protocol is the standard plain CT head, and the goal is really to rule out a bleed. CTA usually follows, looking for an occlusion for potential thrombectomy. Early on, you might see a hyperdense vessel, usually the MCA, sometimes the basilar tip, and occasionally that's your only sign. After that, loss of grey-white differentiation, classically in the insular ribbon, then hypodensity as the infarct declares itself. Later signs are cytotoxic edema and eventually encephalomalacia. Complications to watch for are malignant edema, causing mass effect, and hemorrhagic transformation. And be careful with posterior fossa infarcts. Look for cerebellar swelling. Easily missed. Not a lot mimics an infarct, and as we said, the plain head rules out a bleed. So once you've described the findings, don't forget to tell the stroke team. Time really matters here for thrombolysis and thrombectomy. Next we have hypoxic-ischaemic brain injury. Plain CT head after an arrest, though be warned the early findings are subtle. MRI shows the true extent. This is a global insult, not a territory. So you get diffuse edema with effaced sulci and cisterns and loss of grey-white differentiation that's bilateral and symmetric. In severe cases, the reversal sign and the white cerebellum sign both carry a poor prognosis. The complication to know is really a trap, and that's pseudo-subarachnoid. The dura looks bright against a low-density brain, but there's no actual blood. Beyond that, the swelling effaces the cisterns and the patient can cone. The main differential is that trap, pseudo-SAH. No true sulcal blood, it's all relative density from a swollen brain. Trauma or a big infarct can look similar, so correlate with the arrest history. These findings carry prognostic weight, so this is one for neurology and critical care. Now we move to the venous side, with cerebral venous sinus thrombosis. Plain CT head, but you'll usually need a CT venogram to make the call. On the plain scan, you might catch the dense delta sign, a bright triangle in the superior sagittal sinus. On the venogram, it becomes the empty delta, which is an enhancing wall with a dark clot in the middle. The key complication is venous infarction. And here's the thing to remember. It crosses arterial boundaries. It doesn't respect a territory. So bilateral parasagittal or thalamic changes should get you thinking venous. These often bleed, and you can get raised pressure and hydrocephalus on top. An arterial infarct respects its territory. A venous one doesn't. And watch the dense sinus mimic, because polycythemia or dehydration will brighten the sinus, so correlate with the venogram. Mention any infarct and hemorrhage in your report and flag it to neurology or neurosurgery. And do go looking for an infective source. Staying vascular, we come to carotid and vertebral dissection. CTA neck and brain, arch to circle of Willis. Think of it in young stroke, and the trauma is often laughably trivial. A minor bump, a chiropractic session. You're looking for an intimal flap splitting true from false lumen, a crescentic mural haematoma, or the string sign, that long tapered narrowing, classically the ICA above the bifurcation. Complications are the reason we chase this. Stroke, of course, but also pseudoaneurysm at the dissection site and distal embolization. So go back and look at the parenchyma before you sign it off. The main differential is atherosclerosis, but that gives you calcified plaque at the bulb, whereas dissection gives mural haematoma without it. Report the artery, the flap, any pseudoaneurysm, and any stroke. That's what neurology and vascular need, as most are managed antithrombotically. Let's turn to pressure now, and that means hydrocephalus. Plain CT head and add MRI if you suspect an obstructing mass. The findings are ventricles dilated out of proportion to the sulci. The earliest sign is temporal horn dilatation, then transependymal migration, that fuzzy periventricular halo where CSF is being forced out under pressure, which tells you it's active. For complications, look for effaced cisterns and herniation. But the real trap here is a bit different, and that's missing the underlying cause. Reporting the hydrocephalus and missing the tumor sitting on the aqueduct is a half-finished report. The main mimic is atrophy, but that enlarges the ventricles and the sulci proportionately, with rounded gyri and no edema. NPH gives ventriculomegaly out of proportion to sulci, but without the pressure signs. In your report, name the level and the likely cause of obstruction, and get neurosurgery involved. And if you're wondering what's driving that pressure, next up is the intracranial mass lesion. Plain CT head, then contrast. You'll see a mass with finger-like vasogenic edema. The real question is what it is, and the ring is your clue. Thin and smooth favors abscess. Thick and irregular favors tumor. Central diffusion restriction on MRI is your best discriminator because pus is a thick cellular soup and it traps water. Complications are mass effect and herniation, obstructive hydrocephalus if it sits on the CSF pathway, and for an abscess, rupture into the ventricle, which carries high mortality. So the differential is really abscess versus tumor. An abscess gives you a thin, smooth ring, restricted diffusion, and a septic context. A metastasis gives you a thick, irregular ring, multiple lesions, and a known primary. Describe the edema and the mass effect, and if it looks like an abscess, that's an urgent call to neurosurgery. Right, that's the neuro done. Now on to head and neck, starting with orbital cellulitis. Contrast-enhanced CT of the orbits and sinuses, usually a child with ethmoid sinusitis. And your whole job here is that line at the orbital septum. Stranding in front of it is preseptal, and that's managed medically. But the moment you see stranding behind the septum, that's postseptal, and that's your danger sign. Look for a rim-enhancing subperiosteal abscess along the orbital wall and name the source sinus. Complications are all sight or life-threatening, and they are optic nerve stretching from proptosis, spread back into the cavernous sinus, and intracranial extension. The differential is preseptal cellulitis, which is not an orbital emergency, and orbital pseudotumor, which has no septic sinus source. If there's an abscess or the optic nerve looks stretched, that's an urgent ophthalmology and ENT call. It may need draining. And if that infection tracks backwards, you land on cavernous sinus thrombosis. Contrast-enhanced CT with a venogram through the skull base. The source is usually a facial or sinus infection. You'll see the sinus expanded with a non-enhancing filling defect, and the sign to know is the convex lateral wall. Normally it's flat or concave, so if it's bulging, something's wrong. Look for a dilated superior ophthalmic vein and proptosis. Complications are intracranial spread and venous infarction. And the cranial neuropathies fall straight out of the anatomy. 3, 4, V1, V2, and 6 all run through that sinus. That's why the eye stops moving. The differential is a cavernous sinus mass. A meningioma expands it too, but enhances homogeneously with no septic source. Worth knowing the carotid cavernous fistula as well, which gives a dilated vein and proptosis, but post-trauma. This one needs urgent neurosurgery and ophthalmology, so pick up the phone. Moving down into the neck, we have the deep neck infection. Contrast-enhanced CT from skull base to thoracic inlet. And the thing to say first is the airway. Stridor, drooling, trismus, that gets secured before anything else happens. On the scan, a rim-enhancing collection with a low attenuation center is a drainable abscess, whereas stranding without a drainable center is phlegmon, and that changes the management. Complications are the airway itself, spread down the danger space into the mediastinum, and Lemire syndrome. Thrombophlebitis of the internal jugular with septic emboli off to the lungs, so do look at that vein. Your differential is a necrotic node, which can mimic an abscess almost exactly, so correlate clinically. Report the space, the size, and whether it's drainable, and flag any airway narrowing or mediastinal extension straight away to ENT. Next, we have odontogenic sinusitis. CT sinuses on a bone algorithm with thin sections through the alveolus because the answer is down at the sinus floor. The giveaway is that it's unilateral, one lonely maxillary sinus, often with a foul discharge. Ordinary sinusitis doesn't pick a side and smell bad. So look for periapical lucency around an upper posterior tooth, opacification of that sinus, air bubbles within it, and dehiscence of the sinus floor. Complications are spread to the other sinuses, an oroantral fistula, and rarely orbital or intracranial spread. The differential is ordinary non-odontogenic sinusitis, which is bilateral with an osteomiatal pattern and no dental source. And the important bit for your report? Name the culprit tooth. The treatment has to go after the tooth, not just the sinus. And finally, otomastoiditis. CT temporal bone on bone windows and add a venogram if you're worried about sinus thrombosis, which you often should be. Now, the key point here is that mastoid opacification alone is not the diagnosis. Fluid in the air cells is common. What you're actually after is erosion of the bony septa. That's coalescent mastoiditis, and that's the surgical disease. So check the sigmoid plate deliberately, because that's your route to the complications, which are a subperiosteal or bezeled abscess, sinus thrombosis behind an eroded plate, and intracranial abscess. The differential to know is cholesteatoma, scalloped bony erosion with a soft tissue mass, a completely different pattern. Report the coalescence, any abscess, and the state of that sigmoid plate, and get ENT involved. And that's part 1 done. We went over the main neurology and head-neck conditions. See you in part 2 for neuro and facial trauma.